Good morning and welcome to our Asthma Allergy Education Workshop. This is the second session in the 2026 series. My name is Megan Ahmad. Thank you for joining us today. I would like to thank our sponsors for making this event possible. For any queries, please email admin@allergyfoundation.co.za. The recording of today's webinar will be made available to anyone who's registered. Our program today will be led by an awesome panel of experts. For any medical professionals in the audience, please note that this is not a CPD accredited event. Before we get started, I'd like to go over some basic housekeeping. This is quite important, especially for those joining us for the first time. The taskbar may be seen at the bottom of your screen. Our audience is muted and will remain muted for the full duration of the session today, and we will not use the hand up function. Instead, we encourage you to post your questions in the Q&A tab. Our panel of experts will answer during the session and at the end during the dedicated Q&A section. You may use the React button to interact with the panel by sending your reactions. Today's program and other downloadable content may be accessed from the Resources tab. Please feel free to visit the links that we've added as well. To access the recordings of the previous workshops, please scan the QR code. Email laik@allergyfoundation.co.za for more information. Follow us on social media and sign up for our free newsletter to receive updates. Our next session takes place on the 1st of August, focusing on rhinitis and conjunctivitis. Visit our website, and that is www.allergyfoundation.co.za, to learn more about what we do and what we offer. Sign up for our free newsletter, browse our articles and free downloadable content, and explore the products under the AFSA seal of approval. Visit the AFSA shop to purchase our in-house products. Should you wish to learn more about asthma management or purchase your AfriSpacer device, please visit www.afrispacer.co.za. Our eczema advocacy efforts continue to grow. Medical aids in South Africa are falling short on chronic care. Scan the QR code, sign our petition today, and join hands for real change. Don't let eczema go uncovered. So you can scan that QR over there and sign the petition. And then lastly, before we continue with the program, I'd like to mention that we have some awesome prizes up for grabs. Today's winners will be randomly selected and announced live at the end. So we have one Mrs. Martin's Beat Allergy starter pack, a respiratory hamper from Glenmark Pharmaceuticals, 2 easy squeezy assistive devices, and 3 AfriSpacer hampers. Please stick around right until the end and we'll announce our winners live. Thank you so much. Before we start, or at least before I hand over to our panel, I would just like to play our very short in-house promotional videos. Thank you so much.
Looking for products that are safe for allergy sufferers? The AFSA seal of approval is here to help. This trusted seal is awarded to products that comply with our strict quality criteria. Look for it on body care products, air conditioners and purifiers, medical bracelets, nasal sprays and washouts, eczema clothing, cleaning products, and many more. Choose your products with confidence. Look for the AFSA seal of approval or visit allergyfoundation.co.za to view the available products.
Let's get into the action plan for achieving a truly clean, truly allergen-free bed.
First step, the HEPA vacuuming. You're gonna strip the bed of everything. Then, vacuum the mattress slowly, using overlapping strokes. You really wanna pay special attention to the seams and the edges. That's where all the gunk collects. And here's a pro tip for you. Always, always empty the vacuum canister outdoors so you don't accidentally release all those allergens right back into your house. Next is the UVC sanitization. And I gotta say, safety is the absolute #1 priority here. The device has to be positioned precisely, and the exposure time is critical for it to actually work effectively. And because this involves certified equipment and pretty specific safety protocols, this is one step that's really best left to trained professionals to ensure it's done right.
Okay, thank you so much for your attention. We are about to start with the program for the day. Over to you, Dr. Deercliffs, to introduce our first speaker, and that is Prof. Charles Verwey. Thank you so much.
Good day, everybody. Thank you very much for joining us on this lovely Saturday, wherever you are. I'm hoping that I believe and that this will be a very helpful and educational session to you. We're looking forward to our speakers, starting with Prof. Charles Verwey, who's hailing from Wits, and he's an expert in asthma, and he's going to discuss with you or talk to you about understanding asthma and some of the basics. We look forward to your participation. You can type your questions in the Q&A or in the chat, and then we will either address them as we go along or in our Q&A session. Over to you, Prof. Charles.
Thank you very much, Mimi, and thank you for AFSA for inviting me to talk today. I'm going to switch my video off so I don't distract myself, and then we can get going. So today's talk is going to be nice and simple. It's going to be about understanding asthma. And if we really want to ask the question in a better way, it's going to be about what is asthma actually. There's many myths and many rumors going around about asthma, and people have said it's people with trouble, they have trouble breathing, they have a tight chest, there's airway swelling, coughing fits, wheezing, breathlessness, lifelong symptoms, allergies caused by exercise. A child is exercise, something happens when you're sick. It's a psychological problem, someone that needs inhalers, it's contagious, only serious when you go to hospital and you can't do sports. And these are some of the things that get said and get thrown around by the general public. And not all of it's true. Some of it is true, but not all of it's true. So today I'd like to get rid of some of the myths and the tales about asthma by just keeping it very simple, and hopefully I know with the definitions that I use about asthma, a light bulb came on in my head, that maybe I can light up some light bulbs in other people's heads as well, so that we can play with asthma itself. I always find that the biggest problem with medicine and the biggest problem with specific diseases is that the definitions we have are so complicated that you can't read past the definition to understand what is actually going on. So I like a very easy definition for asthma, and it's basically recurrent reversible episodes of airway obstruction. So recurrent as in there's just not just one episode. It's reversible. I'll get to that a little bit later. And it's characterized mostly by airway obstruction. And if we want, and you can see on that picture on the right there, that there's different aspects to the airway obstruction. The airway, the normal bronchiole on the left there is nice and open and patent, where the one on the right, there's inflammation, there's airway spasm, and there's mucus production. And all of this causes your airways to close up, so causes airway obstruction. And just to repeat, it happens recurrently, and through different mechanisms, it can be reversed. And that's for me a nice and easy definition of asthma, how I can remember it. Just remember, and all this airway obstruction from asthma it causes wheezing, it causes shortness of breath, it causes chest tightness, and it causes coughing. But remember, just so we remember, a lot of diseases can look like this. So not everybody that wheezes is asthma. So not all wheeze is asthma. So how do we diagnose, or how do we define a wheeze? Because we have to know there's many different types of noisy breathing, but we define a wheeze as a musical high-pitched sound heard on inspiring or expiring. I have to be honest, it's defined as a musical high-pitched note. I don't know how musical it is, depends on your musical taste. If you can, hopefully you can hear that sound that I've made, that's made there. It's a nice high musical sound. And it can be quite subtle. It's not a very obvious sound, but it can be quite subtle. And it's you can obviously hear that it's not a normal sound that should come from a child's chest. But as I've mentioned before, that not all wheezing is asthma. I'm just going to try to flip this. Oops. Okay. There's a lot of things that do cause wheezing. I think just before we diagnose asthma, we've got to make sure that the wheezing is not caused by another disease, especially in the younger children. So not all wheezing is asthma. Wheezing is just a clinical sign that suggests that there's airway narrowing or blockage. And as mentioned before, asthma is characterized by airway obstruction or airway blockage. So yes, it's definitely there in asthma, but it can be caused by many other diseases. And just I don't want to confuse or complicate things, but anything that causes obstruction of the airways, whether you've got complete tracheal rings, whether there's a mass in the chest, whether there's softening of the airways that we call bronchomalacia, whether the child has inhaled a foreign body that causes obstruction of some of the airways, whether there's something like tuberculosis causing big chest lymphadenopathy that can cause it as well. But the most common one definitely is asthma or bronchiolitis. Asthma in the older child and bronchiolitis in the younger child. And then we get slightly more rarer diseases, but very serious diseases such as cystic fibrosis as well. And also if a child aspirates, if they have a problem with abnormal swallowing mechanism or with gastroesophageal reflux, that can cause wheezing as well. So the point I was trying to make is a lot of things can cause wheezing. Um, and asthma, as I mentioned, is not just wheezing, there's other signs as well. So let's break down the definition a bit more. And we can say that asthma is a disease of chronic inflammation. And we know that this chronic inflammation causes the airway obstruction, as I showed in the picture earlier, and this airway obstruction leads to clinical symptoms. And these clinical symptoms are usually wheezing, shortness of breath, chest tightness, and cough. And I just put it in red there just to make an exclamation there. Another way of looking at it is it is recurrent. So it's not there the whole time, asthma. It can come and go. It can be there the whole time if it's very uncontrolled. But one of the characteristics is it's recurrent, reversible airway obstruction. So often it comes and goes. And you'll have areas of more symptomology and areas of less symptoms in the child, depending on the triggers and the allergens and so forth. And one of the reasons for that is that the the children with asthma have hyper-responsive airways. The airways that they have are very sensitive to irritants or to allergens, and they respond to these irritants or allergens by closing up and causing the airway obstruction. So you've got this inflammation that's underlying the whole time. The child or adult is put into contact or exposed to an irritant or an allergen, and because of the airway hyperresponsiveness, it causes airway obstruction when they're put into contact with these, and this causes the clinical symptoms. So a lot of people call it twitchy airways that causes the or tight chest, and that is theoretically, well, it's quite correct actually. It's twitchy airways, which we call airway hyperresponsiveness, and this leads to the clinical symptoms of a tight chest. There's um, a few different contributors to this airway hyperresponsiveness or airway obstruction. So it could be muscle spasm, and we know that's why we give the short-acting beta agonist. And these airway hyperresponsiveness, as I've mentioned, is the airways are very sensitive to allergic and non-allergic triggers. And this then, in effect, leads to the symptoms of wheezing, shortness of breath, chest tightness, and coughing. And the symptoms can vary over time and intensity. So once again, it breaks down to the old definition of recurrent reversible airway obstruction. So just to put everything in a nutshell, and we're almost finished with the definition now, is that you have inflammation and you have twitchy air, causing twitchy airways. That leads to a tight chest, to the airway hyperresponsiveness, and this leads to the clinical symptoms. And these can be reversed with asthma pumps or with nebulizers. There are more signs and symptoms than I've just mentioned. There's the wheezing, there's the shortness of breath, the chest tightness, and the cough. And I'm repeating this on purpose quite often because those are the most common and most important signs. But there are few more clues that we can use to find a child with asthma or to diagnose with asthma. One of those is that the cough is generally non-productive. It's generally triggered by irritants or allergens. There's variation over hours, days, or months. You can have a good period, often during the late summer months or the early winter months when there isn't that much wind here in Joburg and there isn't much pollen flying around, or when you go on holiday and you basically take a holiday from the allergens or the irritants that you have at home where you live. And also that there's always reversibility with asthma pumps, and often there's a family history of asthma or of allergies that can be elicited by asking, taking a good history from the family. I'm just going to play this video quickly, and I do apologize to our tech team when they asked me if I have videos. They said no. I said no. I was completely wrong. So just have a watch of this video quickly of this young lady who developed signs and symptoms of asthma, and she's a known asthmatic. And you can hear that she's wheezing and she has difficulty breathing. And then we're giving a bronchodilator there, a short-acting beta agonist or reliever pump through the spacer. And you can see then at the end how much she improves with this treatment.
Sorry, Prof. Charles, there was no
That,
audio. I think when you share, you need to just share and click with audio so that we can hear the audio embedded in the presentation. Apologies for that.
okay, I can try to do that when she can't hear anything at the moment.
No, we're not able to hear any of the audio embedded.
Okay, let me just stop sharing quickly and I'll reshare again.
So you're going to share with sound.
Yes, yes, share sound as
Awesome.
well. Let's hope I get it right now. Is that better?
Yes, it is. Yes.
Great. So let me start over there quickly. I apologize for that. Yeah, and so I just wanted to show that video just to show you that that the wheezing and the difficulty in breathing and the shortness of breath is a typical sign that we do find in asthma. And when we give a nice bronchodilator, as in that case, the reliever pump, the short-acting beta agonist, you can see how nicely it responds and how much improved the child's breathing is after that, with a decrease in the wheezing and a decrease in the difficulty in breathing. So that's one of the last signs of asthma, or the last parts of the definition, is that asthma, as I said, is a recurrent and reversible airway obstruction, and it can be reversed through bronchodilators, as you can see as we see in the video, but we can also do quite a few tests to check for reversibility to make sure that it is asthma. So like on that video, we can witness bronchodilator reversibility. We can do peak flow tests, and that's a peak flow meter on the screen there. We can do lung function tests, or we can even elicit a bronchospasm or chest hyperactivity by making the child run around and all of that, and then seeing if the child starts wheezing afterwards. And we can also give some medication to elicit a wheeze in the child, but we don't always like doing that, and then reversing the wheeze afterwards. So there should be evidence of reversibility in the asthmatic patient, because that is one of the hallmarks of asthma itself. So that is my quick definition and introduction to asthma. But what I just want to, and for the last few slides, what I want to really talk about as well as the importance of asthma. We know that asthma is an extremely common disease. It's the most common chronic childhood disease around the world, and affects up to 20% of children. And it's definitely the most commonest chronic disease in South African children. And I won't go into the details there, but in South Africa, we're looking at a very high percentage of children with asthma. We're ranked about 25th in the world with the prevalence of asthma, but more importantly, in South Africa, we're ranked amongst the countries that do have the proper data. We're ranked third highest around the world for asthma fatality, and that's actually, I think we're fifth now if I look at the latest data. This is from 2017, but the 2023 data says we're fourth or fifth now. And this is a very big problem because asthma should not be a fatal disease for any child. It is a disease that we should be able to control with good education and good management. So how do we manage asthma? I'm just going to give a quick overview of this. Well, one of the most important parts of the management of asthma is actually patient education and patient and family education. And I thank all of you for joining us today, because that's going to help a lot with patient education. And we need to make sure that the patient has good inhaler technique, is adherent to the medication, and knows about symptoms and knows what to do when the symptoms do become out of control. We also need to manage the allergen and trigger avoidance, or manage allergens and triggers by evaluating the environment, by managing allergens, and then removing triggers where possible. And a big sinner here is obviously cigarette smoke, probably the easiest one that can be removed from the patient's environment. Don't tell that to the smokers, though. And you can see that pharmacotherapy is only one, or pharmacological treatment is only one part of the management of asthma. It's a big part, yes, but it's only one part. But without all the other ones, the patient education and the allergen and trigger avoidance, we won't be able to get good control of the asthmatic patients. So we need to optimize all these different therapies and different management techniques. And then one that we often forget is we need to treat the comorbidities in the patient as well. Treat the allergic rhinosinusitis, treat obesity, treat gastroesophageal reflux, treat food allergy. And there's quite a few things that we can treat to make asthma more controllable. Because the goals of asthma treatment are very simple. It's asthma control. And I think more than just saying asthma control is the child needs to lead a normal and physically active life. And I think the important word there is normal, and then physically active as well. They need to be mostly completely free of any symptoms, attend school regularly, and participate fully in all school activities, including sport. Sleep free from nighttime cough or wheeze, grow and develop normally, minimize attacks of acute asthma, avoid hospitalization, but also avoid and minimize medication side effects. And just by a good management strategy, we should be able to control about 95% of all our asthmatic patients completely. So just to finish off, the principles of manage once again is to control inflammation. We need to know our medication. I'm not talking about the doctor knowing medication. I'm talking about the child and the families and the community need to know the medication. We need to use the medication as prescribed, use the best technique available, and aim for complete symptom prevention, not just treatment. And we do this through a stepwise therapy approach by increasing or decrease the treatment as needed. And we need to monitor and assess the control of the patient. We have a lot of questionnaires that we can do this with. And then we have a lot of tables as well and posters showing all the treatment where we can actually improve the education of the community out there. So in conclusion, asthma is the most common chronic non-communicable disease in children. The inflammation underlies all the symptoms. That's that of inflammation, and that causes airway obstruction. And anti-inflammatory treatment is always necessary in these patients. Inhaled steroids are the best treatment, and it needs to be prolonged treatment with inhaled steroids. And we need to aim for control, not just to treat the symptoms. We have to understand our medication, and we have to use our medication as prescribed and with the best possible technique. And by doing all of these simple things, we should be able to have complete asthma control in our children and in our families. So I thank you very much for listening. And I'll now hand over to Mimi again to take over to the next talk.
Thank you very much, Prof. Shaw, for introducing us and giving us the basics and a few pointers on asthma and where it comes from and how it works. Very useful. And I'll now hand over to Dr. Pieter de Waal, who's going to tell us more about some management aspects of asthma. And Pieter hails from Cape Town and is a pediatric allergist. And he's going to tell us much more about therapies. So over to you, Pieter. Thank you very much.
Dr. de Waal, you're muted. Sorry, Dr. de Waal, you are muted. There we
Better
go.
now? Cool. All right, thanks, Mimi, and thanks to the AFSA team for inviting me to talk. Prof. Shaw has already said a lot about managing asthma and important. I'm just going to highlight some pharmacological treatment aspects of asthma. But remember, asthma is a multi-modality treatment. You need to address all aspects of managing your asthma. So I'm going to focus on treatment, specifically combination treatment, and then all the new definitions that we stumble across nowadays, MART and SMART and air-only therapy, just to show you where these all fit in and how they ensure that we optimize our asthma management when it comes to treatment. So just to remind ourselves, it was World Asthma Day on the 6th of May this year. The theme of this year was is still make inhaled treatments accessible for all. So just to remind ourselves and to highlight once again that inhaled treatment, specifically corticosteroids, is the mainstay of asthma pharmacological treatment. And we still have a huge percentage of patients all over the world and in South Africa that do not have access or do not have treatment when it comes to asthma management. So once again, highlighting that important aspect of asthma management. So why inflammation matters? So Prof. Shaw already told you about the importance that we should recognize that asthma is a chronic inflammatory condition. So it's driven by inflammation, it's inside the airways, it can exist even when your symptoms are mild or even absent. So don't be fooled by the absence of symptoms. There's still, if you are an asthmatic, there's still this sort of lingering, ongoing inflammation in your airways that's just sitting there and waiting to cause an asthma flare-up. Untreated inflammation, if it's not optimally treated, can increase your risk for an acute asthma attack. And then we've got relievers that really opens the airways, but they do not really treat the underlying inflammation. And that's a very important message of this morning. Long-term control requires really anti-inflammatory treatment. And that's important to make to highlight the difference between the two. So inhaled corticosteroids are really the mainstay of treatment or pharmacological treatment. It treats airway inflammation and it reduces asthma attacks and hospital admissions. It has been shown in numerous studies that it does lower your risk for asthma-related death, and it really improves overall asthma symptom control. And then I think quite importantly that we often overlook is that it protects from airway remodeling. So the longer your asthma is uncontrolled, the more severe and the more frequent you have attack, the higher your risk of becoming sort of reversible or a reversible airway remodeling patient. So those damage that has or are being done by your lung caused by inflammation at the end of the day cannot be reversed if you don't address it effectively and address it easily early in your management. So it's quite important to get on the right medicine as soon as possible. So I think a very important thing that we need to remember or distinguish in this morning's talk is the difference between a preventer and a reliever. And that's important to ask your doctor what are these drugs and where do they fit in with your asthma management. So preventers or controllers, some people call them controllers, are really inhaled corticosteroids. There are some other less important ones like systemic drugs that you can take. But inhaled corticosteroids reduces inflammation and it prevents attacks, and relievers relaxes your airways. And most often we use relievers in an acute situation where your asthma flare up. We just want that acute relaxation of your airway, but it does not really treat your underlying inflammation. So it doesn't prevent future attack. It just gets you out of trouble immediately, and then after a few hours when the attack is gone, then you still have the risk of an asthma flare-up if you don't treat the airway inflammation. Most patients need to take both the preventer medication and their reliever medication. And you'll see of the latest trend in asthma management is now that we actually combine the two. So the moment you feel you need a bit of relief, you also need to give yourself a top-up or an extra dose of your preventer medication. So it's important for you to recognize when your symptoms are becoming uncontrolled. We're talking about the self-managing asthmatic nowadays. So know your asthma, know your triggers, know your symptoms. And the moment you see your asthma is becoming uncontrolled, then you act, and you act effectively, and you act fast. So reliever inhalers, it's that little blue pump or little white pump, Astavent, Ventis, Ventimax, we all know them. They give fast symptom relief, and they are all part of a pharmacological class that we call short-acting bronchodilators. So they really are short-acting, they work very fast, they work very quick, and they just relax the airways. And as Prof. Shah already mentioned, they really work on beta-2 receptors to help to open the airways when they are narrowed. They should be used when your symptoms occur, but there are some danger signals here. The problem is if you over-rely on these short-acting beta-2 agonists or short-acting beta-2 drugs, then there is actually the risk that your lungs become too dependent on them and you down-regulate those receptors. So in other words, if you need them in the future, those receptors just say, no, I'm so used to this medication, I'm not going to react to it. So there are some signals there, and it's really been found that people that over-rely on their short-acting beta-2 agonists are really those people that land up in the emergency room having very difficult to manage and having very serious asthma attacks. And then, like I said, when given alone, it can be actually dangerous. Preventers, like I said, is really the important thing to remember here. So they contain mostly inhaled corticosteroids. They reduce the swelling and the mucus inside the lung, like Prof. Shah already mentioned, and they should be taken regularly and as prescribed. Their benefits build up over time, so they're probably not going to show any benefit after 2 or 3 or 4 days of use, but you should use them regularly, and then the benefit will build up over time. It often has been shown that if you stop preventers too early or stop them totally, it can lead to worsening of your asthma symptoms. And then it's been shown also that you need to have good adherence to really lower your future risk of an asthma attack. So why is SABA only treatment no longer recommended? And the reason there is people may actually feel better in that short period of time, but the inflammation still worsens or is still lingering. It may delay the use of proper preventer treatment, so you're just rescuing the whole time, and you're not really giving a real anti-inflammatory treatment to your lungs. And high SABA only use has really been shown to increase your frequency and severity of attack, and it even has been linked to asthma-related deaths and also emergency visits and hospitalization. So the global and the South African treatment guidelines are now being updated or has been updated, and it no longer recommends SABA only treatment for patients with asthma. I know there's still many patients out there that still over-rely on their short-acting beta-2 agonist, on their SABA treatment, but it's really against treatment guidelines, and it has been shown to be not only ineffective over the long term, but also quite dangerous. So SABA-only treatment is dangerous. I think that's an important message, even if you think you have mild or less severe asthma. And then, like I said, frequent SABA use is a warning sign that your treatment must actually be reviewed. You should add your inhaled corticosteroid. So what do we currently define as SABA overuse? And that's really a very subjective definition, but the rule of thumb here is if you use your SABA only more than twice weekly, it suggests poor control. If you use 3 or more SABA canisters yearly, it can significantly increase your asthma or acute asthma risk. And using over 12 or more canisters yearly is then linked to a very high risk. So there's just some numbers. If you think you fit into that category, remember then you may have a risk of developing problems in the future. So monotherapy versus combination therapy. When we talk about inhaled corticosteroids or preventer medication, we can either give them to the patient as monotherapy. That's inhaled corticosteroid. The class of drug is then given to the patient alone, or we can combine them with more fancier drugs. Often we use a bronchodilator in combination with your inhaled corticosteroid. So combination therapy usually uses something like an inhaled corticosteroid plus a longer acting bronchodilator. So here you've got your benefits of bronchodilation. Your lungs open up while you address the airway inflammation. And these LABAs work for up to 12 hours. Or you can inhaled corticosteroids with added LABA usually prescribed if patients do not control on monotherapy alone. So if your doctor or your healthcare provider or your asthma carer think your asthma on monotherapy doesn't control well, and that's important now for frequent follow-ups, then they might step up your treatment to the next step, which is then a combination preventer therapy. It has also been shown that combination therapy reduces severe asthma attacks, and it really has been shown that it has a corticosteroid sparing effect. So if you combine the two drugs, you can lower your dose of your inhaled corticosteroid, and then you can potentially lower your risk of having corticosteroid side effects. Although corticosteroids are considered extremely safe if used correctly and at the right dose. So there's just that asthma or that treatment poster that Prof. Schall showed you. There's monotherapy. There's different classes and different molecules on the market. The one doesn't necessarily work better than the other one. I think whichever one your pharmacy or your doctor prescribe to you, as long as you use them regularly and in the right way. And then our combination therapy, which is really now taken the market by storm. So all doctors are now used to combination therapy, and we're now using that as a step-up treatment for patients who doesn't control or who doesn't have access to for instance, monotherapy. Formoterol is really a game changer, or has been a game changer since it was launched a few years back. Formoterol is now been added as a long-acting beta-2 agonist, but also a quick-acting beta-2 agonist. So it's a quick-acting, but also a long-acting bronchodilator. So it just makes sense that formoterol can now also be used as a bronchodilator while you are giving your inhaled corticosteroid. It works within minutes. It's an excellent rescue medication, but it's normally combined with an inhaled corticosteroid. So once again, the benefit of inhaled corticosteroid with a bronchodilator. So whenever you need rescue treatment, you also give yourself extra doses of inhaled corticosteroids and address that inflammation. So it really should be seen as a special type of combination in inhalation therapy. Your ordinary long-acting beta-2 agonists that's combined with an inhaled corticosteroid does have the combined effect, but this one also has the effect of opening the lungs while it acts fairly quickly. So that's really been a game changer when it comes to acute asthma management and chronic asthma management. So let's get to some of the definitions. So what is AIR? So AIR, you'll see, or your doctor may have mentioned AIR, it really means anti-inflammatory reliever therapy. And that's exactly what formoterol is now sort of positioning, or where it's positioned at. While you're giving anti-inflammatory treatment, you're also giving reliever therapy. There's two types of AIR. You can have either two different inhaler devices where your short-acting beta-2 agonist or your Astavent or your Ventis will be administered first, and then in a different inhaler, you will then give your inhaled corticosteroid. So we often use this in younger patients. Whenever they have an asthma flare-up, they give their short-acting beta-2 agonist first as a rescue treatment, and then that will be directly followed by inhaled corticosteroid, either inhaled corticosteroid alone or a LABA combination. So that's two different inhalers. We also have formoterol now on the market, which I mentioned has been a game changer, where a low dose inhaled corticosteroid and a rapidly acting bronchodilator is administered all in one device. So each reliever dose will then open the airway and treat airway inflammation simultaneously, and it has been shown that anti-inflammatory reliever treatment, the two combined at the same time, does significantly reduce your severity of your asthma attack risk compared to short-acting beta-2 alone. And then more importantly, it reduces that over-reliance of SABA alone, of your short-acting beta-2 agonist, which we've mentioned is so important and a problem. So what about air-only therapy? That's another definition. It just means your inhaled corticosteroid formoterol combination treatment is now used only when you need it. There's no separate daily maintenance therapy. That's usually for your milder, infrequent asthma patients that feels, or the moment they see their asthma is flaring up very infrequently or milder, then they use their air-only therapy. I'll show you now where does it fit into the recommendations or the guidelines. And then the benefit, like I said, you still receive your anti-inflammatory when each time you use your inhaled or your air-only therapy, you still get that benefit of bronchodilation, and it also relieves your inflammation in your airway. And once again, it's safer than SABA-only treatment. And that's exactly what we want. So what is MART? MART stands for Maintenance and Reliever Therapy. And that's just a form of anti-inflammatory reliever therapy. It's considered a step up when treatment for patients which on air-only therapy doesn't control very well. So air-only therapy, when you only use it as needed, but not as on a daily or a more regular basis. And then when your doctor or your healthcare provider feels that your asthma is becoming more severe or you don't control on it, then you step up to something like a maintenance and reliever. So instead of using it only as needed, you're using it on a more regular basis. So extra doses of anti-inflammatory drug is then given when needed. So you've got your maintenance dose, which you use every day, and then with a step up, you also give yourself then extra doses. SMART is just another way of or another form of MART, and it really points to, or it really highlights the use of a single inhaler. So single just means there's a single maintenance and reliever therapy. Something like Symbicort or Dulera is then ideal for this. You only have one inhaler, and then you rescue yourself and you maintain your treatment on daily therapy. The inhaler usually contains inhaled corticosteroid and formoterol, and one inhaler is used for both prevention and symptom relief, and it really simplifies your asthma treatment. Now you don't have a whole bunch of different inhalers which you need to teach yourself how to use them optimally. It's usually a fairly small device, so you can carry it around with you all the time, and it's really it really leads to better adherence to treatment and better asthma outcomes. So this is just a picture from what we as doctors receive from the Global Initiative for Asthma Guidelines. We know that the GINA guidelines, or the Global Initiative for Asthma Guidelines, is really a sort of a standardized attempt for people globally to manage asthma the same way. And there you can see, specifically in adults or children 12 years and older, they use the stepwise approach. So step 1 and 2, if your asthma is kind of infrequent, maybe 2 or 3 or 4 days in a week, you don't wake up in the middle of the night, your lung functions are still fairly normal, then we use air only, anti-inflammatory reliever only therapy. And this is your low dose inhaled corticosteroid with formoterol only as needed. You don't give it to yourself every day, you just know your symptoms, and when it flares up, you start giving it to you as needed. But the step up to that is really then MARD therapy. So here, your inhaled corticosteroid treatment with formoterol becomes more regular. You use it on a regular, often daily basis. And whenever you feel your symptoms is not controlled during the day, then you top yourself up. So you've got a morning dose, often a morning dose and a night dose, and during the day you give yourself extra doses where needed. And the dose, according to the step where you belong in or where your symptoms are currently at, depends on either a low dose or a medium dose, and that will be then a step up approach or a step down approach. I think it's also important when your symptoms are well controlled, you also need to step down with your treatment. Don't just step up all the time. And then the reliever medicine will then be also anti-inflammatory and reliever. So I hope that makes a little bit more sense. So just to conclude, how to choose the right asthma plan for you, I think we are moving towards moving towards the whole concept of the self-managing asthmatic. We want you to know what asthma is. We want to know what your asthma is and what your symptoms and allergens and triggers are so that you can manage asthma yourself. Obviously, you need the help of a doctor, but it's important that it's not your doctor's responsibility to optimally treat your asthma. You need to also to take personal responsibility for your asthma and treat it yourself. So it's a self-managing disease. So treatment will depend on your symptoms, the severity, and your attack risk. I think it's important, doesn't matter what fancy or expensive or new on the market drug is prescribed to you, if you don't know how to use them and you don't treat them optimally, that whole exercise is going to be futile. So please ask your doctor and go and look for resources. Mimi will tell us about resources just after this, how to use your inhaler technique optimally. Avoid smoking and vaping. Vaping is now becoming the new kid on the block, just as detrimental, if not more, compared to smoking for asthmatic patients. Know your allergens, know how to avoid them, get tested for it. Regular follow-ups help to keep your asthma controlled. So asthma is not a disease where you get put on treatment in ICU over a year or two. You need to get regular follow-ups and you need to fine tweak or to adjust your medicine as needed. Asthma treatment is very dynamic, so it's a simple step up or step down. Have an asthma action plan. It has been shown that written instructions are far more effective compared to just your doctor or your nurse telling you what to do. And I think it's important to never stop any form of inhaled corticosteroid treatment without medical advice, because you may run the risk of an acute asthma attack if you stop it without medical advice. Okay, so carry your reliever wherever you go. We've talked about the SMART therapy. Take your preventer medication consistently. Learn the correct technique. Something like a simple peak flow meter can go far or a long way. When you see your peak flow meter or your measurements on your peak flow meter is becoming less and less, you know there's something wrong. Your asthma is getting out of control. Seek help early if your symptoms are worsening, and that's why you should know your symptoms so well. And then I think a good idea is a written asthma action plan where you can see exactly the green, orange, or the red zone that you're currently in, you recognize your symptoms, and then what to do. Thank you.
Thank you very much, Peter. I will go into our next presentation immediately. Right, can everybody see my slides, Megan?
Yes, we can.
Okay, excellent. Thank you very much, Peter and Prof. Verwey, for helping us out with the asthma basics and with some of the therapy. One of the questions that came up in the Q&A was, what is SABA? A SABA is basically your emergency medication or your emergency inhaler. So that is what we call a short-acting bronchodilator, which is what you use when your chest is tight and you immediately use that pump for inhalation to open up your chest. So that is what a SABA is. One of the practical things and problems with asthma is that it cannot be discussed in 2 hours. So I want to introduce you to resources that we've got. So specifically what I'm going to do is the Allergy Foundation of South Africa. Now, the Allergy Foundation of South Africa, I'm going to point you towards this website here at the bottom. Please go and have a look at the Allergy Foundation website of South Africa. It will tell you about products available. It will give you tips. It's got information, and I'm going to explore some of those with you just now. What is AFSA? AFSA is basically strives to enhance enhance the quality of life and to reduce the cost of healthcare of South Africans suffering from allergic disorders. And basically, AFSA is a non-profit organization. It's a non-profit company. It's registered. It's got all the certificates and everything in place for anybody who wants to donate to it. But it's free to use and it's out there. And it was established to basically educate patients, to promote responsible care, and as well as assist with advocacy and to raise funds for professional development, because teaching is ongoing. Things change. We need to educate both healthcare providers, your doctors, as well as the public. What can you find on the AFSA website? So there's an allergy professional search tool. There are some leaflets. It will give you links to the social media pages. There's a learning academy for healthcare providers, so you can even direct your doctor to it. There's a shop, there's some monthly newsletter, support groups, and allergy education workshops. So all of this information you can find on the AFSA website. One of the most important things is walking a pathway with a healthcare provider. And if at this point you are uncertain or you're looking for someone specifically, you can go onto the AFSA website and find a professional. And here you can filter by specialty. So here you will find allergy specialists in certain, whether it's food allergy, asthma, immunodeficiencies, you can find that. They can filter by expertise. You can search by specific doctors. And then you can also search by in provincial, because this is a nationwide application. The AFSA organization is South African. So it will give you an idea of where to find someone specifically that you're looking for who can help you with your allergic diseases, with your asthma. So please have a look at the Find a Professional directory. On the AFSA website, you can also find instructional videos. Now, this is not only related to asthma. You can find information on eczema, how to use your nasal spray, how to do nasal washouts, EpiPens, learning about food allergy and anaphylaxis, how to use your AfriSpacer, which is important for our patients with asthma. On this website, you will find these instructional videos, but these are not the only ones. There are more. I please encourage you to go and explore what information you can find. The videos are short. They're not in depth. They're not intense. It's it's educational for everybody, whether you're a patient, whether you're a healthcare provider. So please go and have a look at those. Then with regards to asthma, so if you go onto the AFSA website, you'll get a banner such as this, which will give you allergy, general atopic eczema, asthma. And under asthma, there will be quite a few topics that you can explore. So myths, what is asthma, asthma diary, how to control asthma, and how to use your inhaler device. And we're going to go through a few of these. So in terms of myths, so asthma, many people suffer from it. It's one of the conditions where many people die in South Africa from it. And it sounds ridiculous almost, but asthma sounds problematic, and it is. But many people have misconceptions about it. And here are some of the things you can go and read up about it. It's better to tough it out than without taking asthma medication. It's important to walk this path with your medical professional, with your doctor. Asthma pumps are not dangerous. Do what everybody's asthma is the same. What a myth that is. So each and every person with asthma needs to see a doctor who can work out a specific treatment plan for you. Some people think that when they've got asthma, that sports and physical activity makes it worse. And actually, we encourage people with asthma. If your asthma is controlled, you should actually be able to do everything normal. Engage in sports, do all the physical activities. Asthma is not emotional illness. So some people think, yes, it's just anxiety. Go read up about this. It's not just an emotional illness, it's a physical problem. And then asthma can be treated with alternative medications. Please go and read up about this very important topic, because asthma needs to be controlled with proper medication as discussed by Dr. Pieter. On this AFSA website, you will also find the asthma diary. Now, for instance, this is extremely important actually to each and everyone who's got asthma, especially difficult to control asthma, even in the moderate asthmas. On this diary, you can print it out and you can keep the diary where you will be able to document your symptoms, whether it's a cough, whether it's a wheeze, whether you needed to use your reliever, your controller, whether you actually, it also helps you remind you to use your controller and your reliever when you need it. And what you can do with this diary is it's extremely helpful when you go with this, when you fold it in to your doctor. So it serves at least two purposes where you can show your doctor what's happening with your asthma. Because it's often easy to go to a doctor and say, yeah, no, my asthma has been good. It's been better. Some days it's worse. What does it actually mean? So this gives us an indication of what's actually happening. It also helps to remind you to use your controller every day. Then the asthma action plan, which is what's something you need to ask from your doctor whenever you've got asthma. Ask your doctor for an asthma plan. Okay. Dr. Pieter mentioned this, and I'm just going into more detail about it. So action plan is available on the AFSA website. You can download it, you can take it to your doctor, or you can request it from your doctor. It tells you about some of the basic things about asthma. You can add your doctor's phone number, the hospital phone number, then specifically your normal peak flow. So one of the best things for a asthma sufferer is to have a peak flow, to know your normal peak flow and to know your best peak flow. And then there are zones on this action plan. So you've got the green zone, the orange zone, and the red zone. Green zone is the go zone. You're okay then. You can do all of these things as mentioned here, and it mentions peak flow, which are greater than 80%. Orange zone is where you get cautions, or you need to take precautions or be cautious of. And this is where you've got cough, wheeze, or tight chest, waking at night with asthma symptoms. And this describes more of the asthma symptoms. And it also tells you where it sits when you need to start worrying with your peak flow. Red zone is obviously the emergency zone. And for this, and it's important to have this because you might not always be able to explain to other people. But if you've got a document like this with you, then you can show people, instruct people, assist people to help you. So very important to have. And then one of the most important aspects of the asthma action plan is here where your doctor need to fill in your controller, your other medicines, and your reliever. What is your controller? And the name should be written in there. You should be told how much to take, how often. And this will help to remind you. Then, when you're in the orange zone, your doctor should fill this in for you to tell you, what do I need to do when my peak flow is between 50 and 80%? What do I need to do when I'm having more symptoms at night, when I have exercise-induced symptoms? And this should be filled in by a doctor to help you. And then, obviously, when you're in the red zone, what do you need to do? Emergency situation before you go to a hospital. So please have a look at the AFSA website. It's a A4 plan, one page. It can be filled in by a doctor, and your doctor should be able to provide you with one of these every time you see them, because asthma treatment is not static. It changes all the time, and it needs to be adjusted according to you. Someone else asked if you can use someone else's inhalers. Once again, your treatment must be adjusted for you specifically. So yes, in an emergency situation where you don't have a reliever pump or an emergency pump, yes, use someone else's pump if it's available. But in general, it's not hygienic, it's not advised. Each person's asthma is different. And that's one of the myths which you can also read up about on the AFSA website. Additional things that you can find out on this website and where there are leaflets provided. What is asthma control? What are the asthma medications? And we've spoken about the action plan and recording your symptoms. Because remember, you need to take your medicines as directed by a doctor, and you may have more days without asthma symptoms. You won't maybe use quick relief medications as often. You might have fewer symptoms at night. You will breathe better, and many avoid permanent lung function damages and changes. If you control your asthma well, follow the recommended treatment regimens by your doctor and record your symptoms. Because you can't control your asthma by yourself. Doctors can't control your asthma with you, for you. It needs to be a situation where you and the doctor work together, and all of these help. So other things that you will find on the asthma educational site on AFSA, and it's impossible to address all of these things within 2 hours. So are you using the correct inhaler technique? And just to mention about inhaler technique. So one of the most important things is that you need to be using your inhalers and medications correctly. And I often think about so it's sort of a joke, but you never know. And your doctor should be the joke about where the doctor asks the patient how they're using their inhaler and they spray it in their neck without inhaling it. And this is one of the problems. It's not because it's because people don't know. And it's because doctors assume very often. So once again, your doctor should be checking your technique. Is it adequate for you? Are you using it correctly? Because if you're spraying your inhaler in your neck, worst case scenario, it's not going to work for you. And that's why I once again say that you and your doctor need to work together on controlling your asthma. So go read up about meter-dose inhalers, the dry powder inhalers, which are not the pumps, nebulizers. Lots of people ask about nebulizers. Nebulizers are not good for you. Discuss it with your doctor. Actually go and ask the questions. And you will find all of this information on the AFSA website under the asthma tab. AFSA also has got YouTube videos. So once again, these are fairly short, but it will tell you a lot. It will learning to live well with asthma. It will tell you about how to manage your asthma with confidence, how to use a spacer of an asthma pump. Some of these videos are a little bit longer, but still not overwhelming. And they're made to educate you and help you and assist you. So if you go onto YouTube, look for Allergy Foundation of South Africa, not AFSA. because otherwise you'll end up on some different topic. But go and have a look at the YouTube videos that are available from the AFSA Foundation. That will help you. In addition to these things and our education on asthma on the AFSA website, you can also download a rescue tab or code, which is a QR code that you can scan or that you can carry on you. So if you're ever in an emergency situation, someone else can scan this code, and you by now, if you get this in the store, you can fill in all of your allergy information, all of your medical information. It's available in one scan. Can also get ice tags where you can have your name, surname, allergies, medical conditions, treatment details, and all things. You can organize that from the AFSA website, the AFSA store. You can find these on the store. And then also AFRI spaces. So spaces are really important in terms of aerosolized pumps. It's very beneficial for both children as well as adults. It increases the amount of medication that you actually inhale. And you're welcome to have a look on the AFSA website about AfriSpacer. Also go to afrispacer.co.za, which will give you more information on AfriSpacers. But you can find and start your journey with AfriSpacer on AFSA website. If you're interested in reading more about allergy and education, you can sign up for the blog post, or you can go to the website to read the blog post. And there's a myriad of information. There are many topics. And just do yourself a favor, just go and have a look at the AFSA website, have a look at the blog posts. They're really informational. They're easy to understand. For both healthcare providers as well as the public, and it will assist you. It's not overwhelming. And then if you'd like to, you can also sign up for the AFSA newsletter and contact. So here you can actually contact the Allergy Foundation by ways of this email, or you can give them a call, or you can sign up for their allergy updates and newsletters. And this is basically just to give you an idea of where to find more information, as we can't cover everything in 2 hours. And that I thank you for your attention. Please go and have a look at the AFSA website. And that is the end of our presentation for now.
Thank you, Dr. Deetloos, and thank you to our panel for those really useful, really informative presentations. I do trust that the audience has learned a lot today, as I have. And we're now moving into our dedicated question and discussion slot. And I would like to thank the panel for managing the questions that have come in so far, and for typing in those answers. Dr. Deetloos, I did see that you flagged something for discussion during this session, so perhaps we could kick off and just go right into that.
Okay, so the first question, there's a post in the Q&A from a mother who has got quite a few questions. So it reads as follows. Sorry, I have a few. This is in relation to my sons, the 7-year-old asthmatic and 5-year-old with allergic rhinitis. Questions. Is it better to administer allergy syrups and nasal sprays to children at night or during the day? Dr. De Waal, would you like to comment on this? If I can put you on the spot for now.
No, it's fine. Thanks, Mimi. I get that a lot. You know what? No, it doesn't really matter. I think it all depends on which allergy syrups are you using. Obviously, we can have a whole morning session again on first and second generation antihistamines. So I assume the person is talking about antihistamines, because that's really our allergy syrups. They have been shown to be, all of them have really been shown to be safe, but specifically the newer generation antihistamines. Unfortunately, there are still the older generation antihistamines that can make you very drowsy and impair your concentration. But we must remember that people also process and metabolize drugs differently. So if your child is saying, Mom, I'm having a bit of difficulty in concentrating, I'm feeling a bit drowsy, in the mornings when we use the antihistamine, then we simply give it to them at night. And there isn't really any difference in efficacy between the two. So if you would feel better and you feel that his concentration is better during the morning when he wakes up after giving it to him during the night, then I'm happy with that.
Thank you, Dr. De Waal. We'll go on. So you answered both the first and the second question. So the second question, is it not too much on the child's system to dose them every day? Which brand is recommended for regular use? Like Dr. De Waal said, there are various brands and they are not necessarily superior ones. You also asked regarding seasonal changes, which months are the key shifts for allergies and flus? So there is definitely the flu season, which starts basically around about April, and it continues through right about up until August, September. So that's for the flu times. But there's also the question about allergies. So when are the seasonal shifts for allergies? And what I can direct you to is the Pollen Count South Africa. So there's a website that specializes, and it's from Prof. Johnny Peters' group and from the University of Cape Town, the Lung Institute, and it monitors pollen levels in South Africa. So go to Pollen Count Daily or the Pollen Count website, and it will help you actually, if you keep a diary with symptoms, with allergic symptoms, you can actually correlate that with the pollen count with the symptoms. So it depends on the key shifts for those ones are, it depends on what you're allergic to. Are you allergic to grass pollen, tree pollen, molds, or what you're allergic to? Then other questions, allergy versus flu meds, what would you recommend? So a lot of flu medication, so allergy versus flu medication, a lot of flu medication has got other medications in that dries up your nose specifically. And for flu medication, yes, it helps. And it also depends on whether it's in the adult population or for the kiddies. In adults, it can really give you symptomatic relief, but remember this is all symptomatic relief. And you shouldn't be confusing allergy with flu medication. So allergy medication is, allergies don't just go away. So especially sinusitis and conjunctivitis and rhinitis, nose problems, they don't just go away. So allergy medication often consists of antihistamines, that's the baseline, and then of often steroids, whether it's in your nose, in your eyes, whether you inhale it. So it's important to distinguish that there's a difference between allergy and flu medication. And then another question, if we were to test for allergies, what are the main things to test for? For this, we can't give you an answer. You need to go to an allergist or someone who deals with allergy, because they first, before testing, you actually need to they need to discuss this issue with you, talk to you, find out when is what happening. And someone who deals with allergy will then be able to guide you in the right direction for what to test. In allergy, we shouldn't just be testing willy-nilly here, there, do a blanket thing, let's see what we find. It doesn't work like that. You need to see a medical professional who can take a history, who can discuss it with you, who can chat to you, find out everything that's happening, and combine that with the appropriate test. How does dairy impact allergies? There is no evidence that dairy impacts allergy at all. It's obviously different if you've got a dairy allergy. But in general, if I'm understanding this question correctly, dairy shouldn't impact your allergy unless you have a specific dairy allergy. What is considered normal and or expected when it comes to sinus or allergy-induced headaches in children? This should once again be assessed by your doctor or your allergist, and they will be able to discuss it with you, find out exactly what the symptoms is, do what we call take a history, and combine what you've told them with the symptoms and what they find on findings. So I would not say that there is a normal or expected because each patient is different and each should be evaluated on merit. Another question, with regard to postnasal drip, at the onset of postnasal drip, which then finds its way to what is the best. Okay, so one of the things is that postnasal drip. So you need to, once again, be seen by someone who engages in allergy. Someone needs to evaluate, are your symptoms of your nose actually allergy in nature, or is it non-allergy? Because postnasal drip is not just allergy. So you need to have someone who looks into what the symptoms of, what nose symptoms you've got. Then the other thing you need to consider is in many patients with asthma, when they've got nasal problems, it often worsens the asthma. So the nose and the lung lining basically runs in one tract. So if your nose isn't well controlled, you often have symptoms of asthma that are worse. Once again, this should be assessed by an allergist or someone who deals with allergies and who's got knowledge in this regard to decide what do you need to control both of these problems. Okay, so that's answering that question. Let's see what else we've got. Okay, so my daughter has been, okay, Prof. Verwey is answering that question. Got another question. My son finds it difficult to breathe when it's windy outside, when he gets cough or flu. More than once it has been happening. Go to the pharmacy, give me a syrup called Ventimax. I think that's the name. Should I say my son has asthma? Okay. Once again, to make a diagnosis of asthma, you can suspect it, but for it to be properly diagnosed, you need to take the patient or the son or your son to someone who has got experience in diagnosing asthma. Because the problem is, so there are two problems. One is that you might have asthma and it is not diagnosed appropriately. So someone might think, yeah, no, you're just wheezing this time and might underdiagnose this. Or the second problem is that you might have asthma and it's not diagnosed. So seek the help of a medical professional in that case. Go onto the AFSA website, find someone who's experienced in asthma, which you'll be able to see on the AFSA website. Take the patient or the person in question to someone who can take a history. First of all, before all of these things, a doctor needs to take a proper history. They should be listening to you. They should be listening, then they should be examining, then they should do the appropriate investigations, then only an assessment should be made. Thank you. Okay, if any one of my other panelists wants to add something, you're
Yes.
welcome. Yeah,
Uh,
go ahead, Peter.
Now I forgot. Now I forgot who asked the question. There was a question about a mum that was asking about her son's treatment and then about side effects and giving a probiotic. So first of all, the probiotic is not going to make the side effects of inhaled corticosteroids less or expose them less to side effects. So she can leave the probiotic. I think there's no evidence to use probiotics. And at the end of the day, they're quite costly and can be expensive. The other thing I want to tell that mum is remember that if you use an inhaled corticosteroid with a spacer and you know exactly how to use it, if you've got a good technique, I think that can minimize symptoms. So make sure you're using it the right way. And then secondly, we also teach patients after a dose or two doses, then rinse your mouth and spit it out. That will certainly help with local side effects like, for instance, Candida infections and so on. But I think In generally, it has been shown in numerous studies, thousands and thousands of patients, that inhaled corticosteroids, even in patients, are safe if they are used the correct way with a good technique, and then obviously rinsing and spitting it out afterwards, or brushing your teeth. So that can certainly help minimize side effects.
Thank you, Peter. And on that note, I'd like to add as well, there was also a question that was asked regarding, well, not a few questions have said that the children are being given prednisone or aspirone. Um, I agree with you 100% that inhaled corticosteroids are quite safe, but there's a lot of evidence showing that oral steroids like aspirone given regularly is not safe. And even one or two doses can cause longer term problems in children. So, my answer to those questions would be for the very young children, the 1 or 2 year old children who develop wheezing and coughing, it's most likely a viral infection that they have. And we know that viral infections do not respond to asthma treatment. And the children should not be getting oral corticosteroids such as aspirone for that treatment. If you are worried about asthma in the child at such a young age, please go see a pediatrician or a pediatric pulmonologist so they can assess whether there is evidence of asthma or whether there's another underlying disease or problem causing these issues. We should completely get away from the habits of giving a lot of aspirone to our children because it is quite a dangerous medication if used incorrectly.
Thank you very much, Prof. Shaw and Dr. Peter. I've got one more question. As a teacher, what do I do if a learner is having an asthma attack or tight chest and they don't have a pump at school? Prof. Shaw, would you like to take this one?
I mean, firstly, a child with asthma should always have their reliever pump with them. Um, it's like me trying to drive to work, but I forget my car keys. It's not good, you know. A child with asthma should always have their reliever pump with them on their person in case this happens. You can also give one to the teacher to keep at school, keep for safekeeping, because an asthma attack or an increase in asthma symptoms can be extremely serious problem and can lead to hospital admission and worse. So if a child has an asthma attack at school and they do not have a pump available, the wise choice would be to call a doctor or to call an ambulance so the child couldn't get hold of the treatment. If it's not severe, then maybe the parents can bring the asthma pump from home, but I wouldn't mess around and look for trouble in case it worsens. The child should then go to an emergency department where they can be treated. Unless it's not severe, but be very careful of that one and rather carry the medication around at all times.
Thank you very much, everybody. We've answered all the questions, the Q&A questions. Thank you very much to our panelists. And I will now be handing over to Megan for our finalization of this morning's webinar. Thank you very much for everybody joining. Thank you very much for our panelists, and thank you very much for our sponsors with whom we would not be able to do this.
Thank you so much, Dr. Dietlefs. Thank you for chairing the session, and to our panel of experts for tackling some of these questions with such ease. I'm now going to announce the winners of today's prizes. Just waiting on my screen to share. There we go. Congratulations. So we had 7 prizes up for grabs today. Chantal Oliver, you've won the Mrs. Martin's Beat Allergy Starter Pack. Anel Kukumur, you are the lucky winner of a respiratory hamper from Glenmark Pharmaceuticals. Taneo Koza and Taskeen Osman, you'll each receive an easy squeezy assistive device. Pulani Mulamodi, Vanessa Dunn, and Leila Khan, congratulations. You have each won an AFRI Spacer hamper. Please note that today's winners were randomly selected. I will be contacting winners at the start of the new week to confirm shipping details. Please do continue supporting us by visiting our website. That's www.allergyfoundation.co.za. We have now come to the end of our workshop for today. I'm going to play us out with a little promo video, just sort of recapping some of the information that I shared at the start of the session. Please remember that we have our next Allergy Education Workshop taking place on the 1st of August, and that will focus on rhinitis and conjunctivitis. If you do need any information, please feel free to email us, and the recording of today's session will be made available to you after the session. Thank you so much for joining us. Have a wonderful weekend further. Take care.